10 years ago, i+solutions was founded with this mission. We want to fight for universal access to essential medicines. Medicines must be available and affordable for everyone. In order to achieve this goal, we must look for the roots of the problem, and a very important aspect of this is supply chain management.
So my name is Maarten van Herpen. I'm now the head of the Philips Africa Innovation Hub. And most of you probably know the company Philips. It's this big multinational company that is active in light and in consumer products and in healthcare. Let me just quickly introduce the part that I'm leading, which is the Africa Innovation Hub. And that is the place where our company is doing its innovation in Africa, for Africa, and also with African talent. And so most of my team is based out of Nairobi. For example, this is an LED light that we developed that is charged by a solar panel and reduces smoke in the house. In that way, improves the health for the people in the homes. And the same with a smoke-free cook stove that we developed. And at the same time, this also increases the livelihoods. So people also benefit financially from these products. But it also improves the health and saves, for example, on pneumonia by reducing smoke. Then looking at the healthcare side, we are working on improving access to healthcare. You mentioned access to medicines, but actually we look at access to healthcare in general, more in a holistic way. Because when you look at the healthcare, at the moment there's just no access for many people. And you described also the situation for these clinics. There are just also not enough doctors on the continent. And also that is not going to change anytime soon because we just cannot train these doctors fast enough. And not even to get it to the level of Brazil. So that means that the only way to solve the issues right now is to innovate and empower other health workers to give the care that normally a doctor would give. And I've brought a few examples. This baby here is wearing a device that is counting the breathing rate of a child. An automated respiratory rate sensor is needed to diagnose pneumonia, pneumonia being the #1 killer for children in Africa. And this device helps to do the diagnosis, but it's a $30 gadget that we can give to community health workers so they can do the diagnosis and then make sure they get the right medicines. Currently, a lot of this is misdiagnosed and babies get treated for malaria instead of for what is actually killing them. Another example is a device like this one, which is used during deliveries. It is a fetal Doppler. It shows you the heart rate of the baby during the delivery, so when it's still in the belly of the mother. But the ones that are existing, the technologies, they were either too expensive, too difficult. This is made much simpler to use. It also has a backup power, because power is a problem in many cases. And the ones that are out there, they break down. They fall down tables and they break down. And this one I can safely toss it on the ground. It happens, and it's one of the reasons why these things are not being used very much. And this one will have a lot more use. Now, because it's about innovation today, let me also talk about some of the barriers to innovation that we are experiencing. Because we see a lot of those pilots across the continent that never reach scale. And I see a very important barrier here. And the first one is that the kind of innovations that you see here are focused at a target group that is currently not the customer for these companies. We're talking about people in low resource settings in Africa, far away from the cities. We're talking about poor people that need these lights. This is a target group that the company doesn't consider as their customer, and which means that they don't listen to these customers and they don't innovate for them. And that is an important problem because looking in the structure, also in Philips, if you look in the structure of our company, there's no business unit that considers these products as their products for their customers. They will ask their customer, which is the big hospital, and the doctor will say, no, this is more something for in the community health worker setting. So that is one of the big barriers to innovation. And the second one is the business model itself. And to sell a product like this one to a community health worker or this to a midwife is very different from selling an X-ray scanner to a doctor in a hospital. And so that the business model has to change completely. And that combination, new customer, new business model, is killing for innovations. Any CEO that knows what he's doing will listen to his customer and use his own business model, so he stops this stuff. And that's why I think we see so many of those well-meaning pilots that never reach scale. They get stopped before they reach that scale. Now, what is the solution to this? And that is the big idea also behind the Philips Africa Innovation Hub. The solution is that you need to create these new businesses in an independent way, independent from the normal way of working in the company. And we do that by an independent structure, where we have a process and a structure that continuously takes ideas to pilot, and then from pilot to scale. And we do that by simulating a startup way of working. So in my team, there are venture managers. They are setting up these businesses as if it is a startup company for them. The two of the guys are sitting over there. And it's really about trial and error and setting up these new business models, and that is really working well for us. One of the other examples on health system strengthening, which is also our biggest project, that is our community life centers or community care services. What we did there is we looked at the primary care, so the community-based health facility, and looked at the quality of care there, which is very, very low. There's no access to healthcare because at these community locations there is basically no service. And we looked at what can we do to improve that situation. What we did is we started a public-private partnership with the local government and basically co-created the ideal community clinic. And what we found is that it's not about one problem. It's not about just malaria medicine or TB medicine or an ultrasound machine or whatever. The problem is much bigger than that, and it is a combination of factors. And so the solution is also holistic. We need to get together with a lot of different partners in a program to really address the issues.
The National Strategic Plan 2012-2016 is aiming at universal access, and the national goals are 0 new infection, 0 death, and 0 discrimination. And the 3 global impact results are 1, new HIV infections are reduced by 50% in 2016, and 2, HIV-related deaths are reduced by 60% in 2016, and 3, the governance and management of the response are optimized at central level and decentralized. So what are the achievements? First, the HIV test realized. We have multiplied by 10 the number of HIV tests realized since 2011. The number of patients under ARV treatment have been multiplied by 2 since 2011. And the conclusion is that despite a low HIV prevalence, a low number of patients under treatment, and the fact that Morocco is a middle income country, major prices decreases have been achieved. The first line ARV treatment cost divided by 100, the biological reagent cost divided by 4, and the methadone cost divided by 4.
The contraceptive security, it is when everybody is able to select product to obtain and use quality contraceptive whenever he needs it. The routine supply chain monitoring and reporting system in Rwanda is all activities conducted by different level, by different person to improve the supply chain management. And the LMIS is a system to manage the logistics information. The strong supply chain is essential to achieve the contraceptive security, the successful health programs and public health goals, including reducing maternal morbidity and mortality. The achievement so far, now all public health facilities are offering the family planning services, the 100%. And the average reporting rate for the health facilities, for the service delivery point, is above 90%. But for the district pharmacies, it's 100%. They are reporting every month. The stock out in the country for the family planning product at national level now is under control. All products are available at central level. However, at district pharmacy or at health facility level, we are still facing some stock out below 5%. This is the the figures to show you that from, for example, for the all method combined, it was 17% in 2005, and today we are at 53.
We as a government, we are not only a donor. That's most of the time we are looked upon as the one with the money. But I think we also have other responsibilities and possibilities to influence the access to medicine agenda. And that's for supporting Global Fund not only with money, but also think and connect and facilitate that different people from private sector, from NGOs and Global Fund and the UN and the World Bank sit together to really work together on those problems.
You know, it's a real exciting time with the Global Fund and where we are with the SDGs that were just adopted. I think you should know that the support from countries like the Netherlands and the leadership of countries like Rwanda, programs supported by the Global Fund have now saved 17 million lives, which is pretty extraordinary. And we're on the path towards ending the epidemics and can get to the end of these 3 epidemics while building resilient health systems if we stick with it. So it's a really exciting time. But there are real challenges, and procurement and supply chain are among the biggest. So I just want to tell you about an analysis we've done recently. We now do really intensive cash flow analyses and forecast versus actuals, which those of you in the private sector would be very proud of a public sector institution that's actually doing this kind of stuff. And what we found is that there are about 20 countries that account for a significant differential between forecasted disbursement, and we disperse money when a country needs it so that they use it to spend. It's a performance-based financing approach. There are about 20 countries that account for a significant differential between forecast versus actual disbursement of funds. And we've done an analysis of why. You know, what are the blocks? It's not because people are lazy. What are the blocks that are keeping money from being used now so that we can get access to products? And one of the biggest blocks is procurement and supply chain. As an example, I was just in Ghana and met with President Mohammed. We signed a new grant over the last 10 years. Ghana, which is a pretty developed country from a health system perspective, they've got great community clinics. They're building an enormous community-based infrastructure. They've only spent 60% of the money that was allocated to them. Meanwhile, they have significant need, and the reason is procurement and supply chain. And now they're really focused on that procurement and supply chain issue. And this is procurement and supply, we find, is one of the largest inhibitions to getting not only to the last mile, but to the first mile in many cases. Outside, as soon as you get out of the city, the first mile out of a city, the problems begin. And even in the city in some complex areas, like underserved slum areas. So it's a huge, huge issue. And it's an area that our board has asked us to focus on because about 40 to 50% of all the expenditures we have on an annual basis, which is about $2 billion, is related to commodities. It's related to procurement and supply. So this is an area where we very much need to engage because it's a block to the use of funds, but it's also an area where we have enormous expenditures. And by we, I mean us. I mean, it's the countries that actually use and expend the money, but that's where the block is. So what can we do about this? I mean, how can we engage to create better solutions? I'm probably going to talk a little bit more about procurement because I think we've done a lot more on the procurement side. And then I want to talk about supply a little bit because that's an area where we think there's enormous need for growth. And i+solutions actually has been doing some great work in Nigeria I'll mention briefly. So on the procurement side, we had something called voluntary pooled procurement, which, you know, to be honest, was neither voluntary nor particularly pooled. We now have a real approach that we just call the pooled procurement mechanism that countries are opting into now because it's working extremely well. We had about $300 million under management. i+solutions is actually one of the key partners here, in fact, the partner. We're actually projecting to get to $1.2 billion a year by the end of next year or thereabouts. And through this mechanism, by direct negotiation and taking out some of the middle partners that we'd always had, and by pooling who procures. So for any individual commodity, there's a different pool of people that make up the vast majority of the market. So bed nets, for example, we're about 40 to 50% of external support financing for bed nets. But if you add the US President's Malaria Initiative, UNICEF, and DFID from the UK, we get to about 80%. So your ability to do negotiation, especially when you do direct negotiation, when you're at 80% of the market, is substantially better than 50%. If you look at antiretroviral therapy, it's South Africa, PEPFAR, and the Global Fund, and you put us together, and that's almost 90% of external, in the case of South Africa, internal pooled procurement. So we've saved, by doing pooled procurement in a smarter way, about $500 million over the last couple of years, using basic private sector practices. You know, that's great value for money. But we have to go beyond that. So countries like Rwanda, the Minister of Health actually opted in. You know how strong Rwanda feels about their national procurement, as they should, because it's a good system. But we pointed out to them that they could save $20 million and close their bed net gap if they use the pooled procurement mechanism on their own, with their own decision making and their own money from the Global Fund, but their own, and they close their bed net gap by using this pooled procurement mechanism. But an issue is, what does a country do as they're transitioning from the Global Fund, or what does a country do if they make a decision to buy their own products? And I'll give you an example of Swaziland that was paying twice as much as they needed to for antiretroviral therapy. They made the smart decision to begin buying all their own first-line products because they're a middle-income country. So they switched from us supporting them to them buying all their first-line products. They're paying twice as much as they needed to because although they have a lot of HIV-positive people, they had to go on the global market with a very small number of people on an annual basis and compete on the global market to win the products that they needed. And that's not easy to do. Now think of all the other countries that have to go out, not just for antiretrovirals, but for every health commodity. And imagine what happens when they transition from external support and now have to negotiate product by product, commodity by commodity. That's a horrible system. It's actually pretty good for companies. It's not particularly good. It's good for the supplier. It's not very good for the buyer. So the pooled procurement mechanism is great, and countries can use it as they want through their own mechanism, but we thought we needed something better. So we actually challenged our team. How are you going to support countries in transition to have a pooled procurement mechanism be effective for them, something like PAHO? And what they came up with is actually brilliant and simple. Do an online mechanism like Priceline or Kayak.com, or basically create a PAHO.com that allows pooled procurement from anyone. So Thailand can join with Swaziland, that can join with Honduras, and have one mechanism where you go on, just like you would for a hotel, and say, I would like to get X number of bed nets delivered on X date. Who can I get them from and at what cost? And you can do drop-down menus for example, does the regulatory approval allow it? So you'll actually be able to see what you could have gotten if your regulatory authority had the drug approved, which could help drive regulatory issues. We're already talking with regional regulatory authorities. They're saying, oh my God, if I had that and I could go to my ministers and say, this is the money we lost, we could get regional regulatory approval or even Africa-wide regulatory approval in a much more rapid way. You can also do drop-down menus for on-time delivery, which we fully intend to do. Just like when in Uber you grade your market, it's not just price, it's can you get it to the site on time. So you'll be able to see on-time delivery through that mechanism as well, which could actually drive better on-time delivery. So it's a very exciting mechanism that we're fairly far along in development for. We're first going to pilot it. We've worked with several countries, had them sit side by side with the procurement agents to run through what that looks like. They've actually had great advice on what needs to change in order to make it work well. And they're hyper excited about it because they're seeing already what it will do to their procurement system. So you will get the lowest price product always available to that country. You'll be able to see regulatory and might drive regulatory change, and we might be able to drive on-time delivery in a way that we can't do. But think of what else it will do. Think of the procurement systems we all had to build. Countries won't have to do that. They'll literally need 3 people sitting in a room with a computer to do procurement. And the transparency in that, both global transparency but country transparency, is enormous. It's pretty hard to steal money if you can follow every transaction, every time, every minute. So the opportunities of this kind of innovation is extraordinary. So we went from a pooled procurement mechanism voluntary pool procurement mechanism that didn't work, that countries didn't want to use. So pool procurement mechanisms that countries are opting to use. Now we're moving towards the next generation of what would a global public good around procurement look like. And that's really exciting stuff, we think, but we'd love to hear what you think. The countries love it. Thailand was opposed. They said, nah, we have our own system, we're doing pretty well. We went and showed it to them. Now they're thinking about changing their procurement system to this procurement system, depending on how it works. That's huge, and we hope it will make a big difference in procurement and start limiting, getting rid of that bottleneck. But supply is an even bigger issue. And if you look at it, I would bet we're actually bleeding more money in the supply chain than we were in the procurement chain because of the multiple steps. And it's really, that's how you get to the last mile, the first and the last mile. And there are so many intermediary partners, and people ran so hard to get stuff up and running that the national systems aren't what they need to be. And so we were looking really intensively at how we, since supply is such a huge piece, and certainly for the last mile and vulnerable populations, how we build a global public good similar possibly to the e-marketplace or something like that, but also how we support countries to have a supply chain that will work. And one example is with i+solutions in Nigeria, where literally all of the partners there have dumped an enormous amount of money into the supply chain. It was completely uncoordinated. Everyone had their own little piece. We actually went in together now and have one unit in the Ministry of Health that is working to support the supply chain in that country in a coordinated way for the country. And we think we'll actually get there. And if you can get a supply chain in Nigeria, you can get it pretty much anywhere. We've also partnered with the private sector. Coca-Cola is pretty good at distribution. When everyone thought about with Coca-Cola is, oh, we'll throw stuff on their trucks. That's a pretty bad model, right? I mean, that's not gonna work. What you can do, though, is stick people with from Coke who know supply chain into the Ministry of Health and work with the Ministry of Health to build a supply chain. And that's exactly what they did in Tanzania. And now we're working to support them in 9 other countries. But we need to go better than that. And this is where I kind of want to end. Is there a mechanism, for example, building off e-marketplace, where innovative entrepreneurs could build a supply chain off the back of that? Because you'll actually be able to predict where drugs are going for a long period of time over multiple things, actually where commodities are going. And it doesn't have to be to a country. It can be to a region. It can be to a big hospital. You can then start doing drop shipments. You could actually create a supply chain that mirrored the procurement chain to break through some of the bottlenecks. We're not going to be able to figure that out. Someone's going to have to. So there are huge opportunities if we use technology, if we use our heads, and actually if we just do simple things. The number of people who said, oh, why hasn't anyone done that? That's the first thing you always hear for a brilliant idea. Oh, someone should have done that already. So why didn't we do that already around supply chain? Why didn't we do that already around getting to the last mile? And that's where we think the excitement is. And it all began with an analysis of actual versus forecast, just simple cash flow. So we're very excited about all this. We really thank i+solutions and the other partners, and in particular the leadership of countries like Rwanda with support of countries like the Netherlands to make all this possible. Thanks.